Good afternoon, everyone. I would like to welcome all of you in the Retinal Grand Round lecture today, which is gonna to be given by Dr. Marcus. He's a graduate of medical schools in Hospital de Rubio University of Barcelona and residency in ophthalmology in Hospital de Bellevitge University of Barcelona. He's having more than 40 publications with more than 18 chapters books. He's really an active retinal surgeon and really is having a great experience in the field. And he's gonna to give us talks about visual and functional outcome of Rhegmatogenous retinal detachment outcome. Dr. Marcus, please.
Thank you very much, Hassan, for this nice presentation. Really delighted to do this grand round today. I'll share my screen and you tell me if it's working. It's okay? It's working? Can you hear me?
Perfect.
Perfect. So today we're going to talk about a topic I think really interesting, not only for vitreoretinal surgeons, but in general for all general ophthalmologists and people who deal with retinal detachment on a daily basis. We're talking about the anatomical and functional outcomes in rheumatological retinal detachment. Not working. Perfect.
Click on the screen, doctor.
Okay. Okay, perfect. So usually we have sometimes a clinical problem when we deal with rheumatological retinal detachment surgery. These patients, they will have successful anatomical outcome. It means with the retina is flat after the surgery, but they have poor vision after the surgery. It means that they have a poor functional outcome. Today, we're going to focus on these results and also how can we be able to assess the success of the surgery. Some definitions to start our journey. So what do you call a primary retinal detachment? So it's an acute retinal detachment that don't have any kind of previous vitreoretinal intervention. There is something similar but not equal. We call it non-complex retinal detachment. These retinal detachments are the retinal detachments, but excluding the retinal detachments, they have giant retinal tears. They can also related to inflammation, or they have previous PVR, or they are previous intervention, vitreoretinal intervention like a post-spinal vitrectomy, or they are trauma related, or they are special cases like patients with retinal detachment with high myopia, or pediatric cases. Why is it important to speak about these non-complex retinal detachments? Because these non-complex retinal detachments are retinal detachments that have low risk of PVR. And we'll highlight later on, which is important to know about that. So we're talking about a group of retinal detachment that usually to fix it with surgery. So let's continue with the definitions. What we call anatomical success. So anatomical success is when we do a surgery on a retinal detachment and we assess the patient as flat with no tamponade. There's some small concepts that usually you will be seeing in all the literature is the single surgery success rate, which is how many retinal branches get repaired after one surgery. This something similar, but is not exactly the same concept, but it's a single surgery anatomical success, which means also how many cases can be repaired after one surgery anatomically. And there's another concept which is a little more broad because they get a better view of the results of the outcomes of retinal detachment surgery, is the total anatomical success. We're talking about how many retinal detachments we repair after one or more procedures without tamponade. But when we talk about functional success, we talk something completely different. So successful success means how many patients they have retinal detachment and the visual acuity get preserved or improved after the surgery. So going to in depth into the anatomical success. So What are the factors influencing anatomic success? There is a lot of factors we're going to have an influence, direct influence into these success rates. First of all, the type of retinal detachment. We will think about patients with a non-complex retinal detachment. Probably they are going to be higher anatomic success than the patients have complex retinal detachment because they have different morphology or PVR. Also, timely intervention is a key topic because acute retinal detachments are usually easy to fix than the chronic ones. Also, the type of surgical repair and the type of therapy you use during the surgery, like a pars-plana vitrectomy or scleral buckle, or the joint of scleral buckle pars-plana vitrectomy or pneumatic retinopexy, and also the kind of tamponing we're going to use in every case, they will have influence in the anatomical success. One probably on the main factors we're talking about, which is the influence in the anatomical success, for sure is the surgeon experience. But there's other factors, patient factors, like how many previous surgeries that the patient have, where did the patient live, what kind of comorbidities they have. They also have a direct influence in the anatomical success and the decisions we make during the choice of the surgery. We need to put that phrase in your mind. But the aim of the retinal detachment repair is to achieve the highest rate of single surgery success, since this is the primary factor for better anatomical function outcome. So whenever we make our choices about the surgery, the tamponage, we have to put in our mind that our goal is to achieve a surgery success in only one surgery. So how many can we account for the anatomic success? What numbers we play on this? So regarding the type of surgery, if we see different kinds of series, so how successful are we doing retinal detachment surgery? So usually it depends on the series, but usually the series goes for 68 to 90% of the cases. We can be successful anatomically after one surgery. If we focus on the information we are going to get for the randomized clinical trials, so for scleral buckles, the success rate goes from 53 to 83%. In pars-plana vitrectomy, the success rate goes to 72 to 93%. And in pneumatic retinopexy, the success rate goes up to 81% in fake patients and 67% in pseudo-fake patients. All this data as extracted from the three, probably the most important clinical trials that we have in this pathology. So all these three clinical trials, two of them are quite old. There's the one from Heyman. It was compared scleral buckle versus primary vitrectomy in retinal detachment. So this study, the main conclusion of this study is there was in fake patients, the rate of reattachment, anatomical reattachment with scleral buckle and pars-plana vitrectomy are more or less the same. But pars-plana vitrectomy is superior in pseudo-fake patients. There is another study by Barthitikos and collaborators. It's compared pars-plana vitrectomy, but the scleral buckle, but in a subgroup of patients, not only all retinal detachments, but the pseudo-phakic ones. So this study only speaks about pseudo-phakic patients, and the rate that the rate of the visual acuity for the patient doing scleral buckle or pars-plana vitrectomy are more or less the same. But there is a small trend of single success surgery with pars-plana vitrectomy. The last but not least study is brand new, and everybody is speaking about that, is the pivotal trial, is Makeup Hiller and collaborators, that is comparing vitrectomy, pars-plana vitrectomy to pneumatic retinopexy in a small subgroup of patients. We need to highlight that not all these three clinical trials, they speak about the same kind of patients. And this is very important just to be able to compare which is the success rate for every technique. So in this study, they say that pars-plana vitrectomy and anatomical repair are more or less the same. And also the single success rate for surgery is a little bit better also for pars-plana vitrectomy. So when we talk about anatomical success, also we need to talk about which is the type of detachment we hear. So what is the characteristics of the detachment that can be in favor of good success? So first of all, if you have a previous pars-plana vitrectomy, it speaks about worse success rate. Also, patient with inferior breaks, this speaks also about worse rate. High number of breaks, and also they have the 4-quadrant detached. Is probably these 4 characteristics of the retinal detachment that precludes that the retinal detachment is not going to be successful surgery after one surgery. But there's some people, they study some curious things. So for instance, Baker and collaborators, they do some studies using retrospective studies with a huge database of patients. And for one of the funny things is that he finds a minimal influence on results due to major ophthalmology meetings. So it means we are in an ophthalmology meeting, the rate of retinal detachment, the successful retinal detachment is more or less the same. But curiously, if you get the diagnosis of the day away week, if you get the diagnosis of a retinal detachment on the weekend, you have more chances to recover pneumatic retinopexy. And also you have more chances to have a reoperation later on. And probably the most interesting study, which is a very complex study, was how is weighting, which is in the decision about how we repair retinal detachment, which is the most influence characteristics that they makes decisions for the surgeons to make on. So usually after the patient characteristics from the retinal detachment, the second more influence is the surgeon. So it's the surgeon who usually decides which is how do you do the surgery, which kind of surgery, which tamponade, etc. There is another study from Starr and collaborators from the Pro study group that they made a comparison between surgeons that make higher success rate and lower success rate. And he found that the successful surgeons, usually they use more primary scleral buckles and more combined scleral buckles and post-spinal vitrectomy. They use less perfluorocarbon during the surgery, and they do less 360 laser retinopexy. So something to remind on. So going overall about the summary about anatomical success for retinal detachment. So if I'm doing retinal detachment surgery, which is the ranges of success I have to speak. So probably if you go and for single success rate between 70–80% of the cases, you are fine. And if you achieve a total anatomic success of 90–95, you are fine. The most important factor for anatomical failures is PVR. That's the reason we told you that the non-complex retinal detachment are patients with low PVR case. So it means patients that are going to be easy to be flatter after the surgery. But the second most important factor for anatomical failure is failure force. That means visualization is also a key point during the surgery. So we move on to speak about the success of success. Functional success is something completely different. The problem with the main variable for success is visual acuity. And visual acuity, if we study as a variable, they have some special characteristics you have to always take into account. First of all, it's subjective. It depends on the patient. It doesn't depend on the doctor or the machine. The good thing about that is we can do quantitative assessment. So we can do comparison with using quantitative to other quantitative variables. But it's a variable that have low inter-individual reproducibility, and also they have low intra-individual reproducibility. And there is lots of factors can influence the results, like refraction, laser stature, etc. So when we talk about preoperative assessment for retinal detachment research, we usually get demographics for the patient, age, sex, etc. We always record the preoperative visual acuity, the extent of detachment, number and location of tears, and it's something very important, macula on and macula of patients. That's key. Also, the lens status, the PVR and grade, there will be characteristics that we need to assess during our research. Why is it important to know the relationship between the macula on and macula of patients? Why? Because there is a relation between the macular status and the visual acuity. And so when we speak about retinal detachment surgery, we need to know that we deal with two different kinds of patients. First patient is the patient with the macula on, they have a good visual acuity, and the surgery goal is to maintain this visual acuity. On the other side, there is macula of patients, they have bad preoperative visual acuity, and the surgery goal is to improve the visual acuity. And it's really important to assess before the procedure with the family, which is the goal of the surgery. if you spend 10 minutes before the surgery, maybe you will save hours of explanation after the surgery. So this is from one of my own data. So this is a graphic that shows the retinal detachment surgery, which is the preoperative visual acuity for this patient. As you can see here, the red dots are most of them accumulate in the superior part of the graphic, and the blue dots are accumulated in the inferior part of the graphic. It means the macular patients, they have a good vision, and the macular patients have very poor vision. That's what we talk about these two subpopulation of patients. So if we go deep into the topic, so what can we say about the functional success regarding the type of surgery? For instance, for the scleral buckle, probably the most important feature of the scleral buckle is the persistence of retinal fluid. The problem is always in the scleral buckle, the subretinal fluid takes longer to be absorbed. The good news is that if you have persistent retinal fluid, they don't worsen the final visual acuity for the patient, but they can delay the recovery. Also, if we get information for the Rhegmatogenous trial, we know that usually phakic patients, they do better with the scleral buckle than post-spinal vitrectomy patients. But the visual acuity is the same for the phakic patients. Why? Because in scleral buckle patients, the cataract is uncommon. But also, there were some changes that is typical from scleral buckle surgery. It is the myopia induction. So when the scleral buckle, especially the circumferential scleral buckles, get tight, we change the axial length of the eye and we induce any myopia changes for the eye that need to be corrected with glasses. Opposite, when we speak about post-spinal vitrectomy, some of the things that we have to take into account for success on this is we can transform macula on into macula of patients. We speak a little bit more after that about this topic. And to have pathology on the macular area is not uncommon after post-spinal vitrectomy, like epiretinal membranes and macular edema that they can preclude also the functional outcome for the patient. Usually visual acuity is worse with post-spinal vitrectomy. It's the same with pseudophakic. And also, if we compare post-spinal vitrectomy with pneumatic retinopexy, the visual acuity are similar results. But the cataract induction is very common in the patient with post-spinal vitrectomy, and also this cataract will do a myopic shift. Last but not least, we can talk about the effect of the pneumatic retinopexy in a functional success. Patients with pneumatic retinopexy have faster visual acuity improvement compared to post-spinal vitrectomy patients. And they have less vertical metamorphosis also compared to post-spinal vitrectomy. But, and also the cataract is uncommon. So it seems that it's a very physiological way to solve the retinal detachment. But we need to take into account that most of the retinal detachment we're exploring other clinical trials are not well fitted into the profile of the patient we'll study on the pneumatic retinopexy trial. So this is something we have to take into account. So then we have the problem. So the retina is flat and we don't have a good visual. Then what can we do? In ophthalmology, you have a group of tests. So some of this become objective, half of this becomes subjective. And some of that is based on anatomy, some of it based on function. For instance, a clear anatomical objective test is OCT. And a clear functional test objective is electrophysiology. On the other side, there's subjective tests like a microperimetry or visual fluid that depends on the patient and it's based on the anatomy. And there's also a subjective test based on function, like a visual acuity, which is the most frequent one, we use it, but also the PAM, the power acuity meter can also be an example of these subjective tests. So when we assess a patient with a retinal detachment, we want to study the characteristics of retinal detachment, we know that it's better to assess something is objective than something is subjective. And also it's better to assess something is quantitative than something is qualitative. We always face the dilemma between imaging and function. And also, one of the main problems is if we study too much patient, two different patients with two different surgeons and two different treatments, it's really difficult to achieve conclusions. So we want to do research in this specific topic. we need to deal with a small group of patients that can be able to be assessed in a good way. And this is what I'm going to pick right now about our experience in anatomical and functional outcome in retinal detachment surgery with my group from Barcelona. So first study was my PhD thesis in 2011, which is a study we try to correlate final visual acuity with objective anatomical and functional variables in primary retinal detachment. We choose 23 primary acute retinal detachment cases operated by the same surgeon with the same technique. Half of them more or less with macula on, half of them macula off. We use the best objective anatomical test we have available at that time was a spectral domain OCT, and we use the best objective functional test we have available at the time, which is a multifocal ERG. And also we were very interested to speak about concordance. Why? Because concordance is a measure of reproducibility. Because if we measure something and we don't know if we are measuring in a good way, the conclusion we're going to get, they are not going to be good. So for us, one of the main goals for our research is to know exactly if there is concordance between the quantitative and the qualitative variables we're going to record on this space, on this group of patients. So for the OCT, we do quantitative assessment, thickness of the macular area, volume of the macular area, as you can see in the graphic here. And also we see qualitative assessment. If the patient has a retinal membranes or retinal fluid, gaps in the outer retinal layers, or gaps in the external limited membrane, etc. These are some examples of these images we obtain for analysis here. There's some cases with subretinal fluid, some cases with an atrophy of the macular area, some repairs, etc. Also, when we study a multifocal ERG, we concentrate on the macular performance here because we are to compare the macular performance to the visual acuity, which is a measure of central retinal function here. So we use the ring pattern. That means that we measure in every ring, we measure the amplitude for P1. It means that if we have higher amplitude, it means there's a better function of the retina. So as we said before, when we study patients with a macula on, macula off altogether, we deal with two different groups of patients. This is the macula off patients. They also have a good performance and they improve the visual acuity. And we have patients with macula on that maybe they're going to preserve the vision, but maybe some of them they're going to lose the vision, especially after cataract surgery. And one of the main goals is it's a successful surgery, the vitreoretinal side for this patient. So we can compare it to that. This patient probably the visual acuity is huge different from one night to the other, but the final acuity for the whole group was quite similar. Look at the performance of the patient with the macula off retinal detachment. They improved 12.5 lines, which is a huge improvement in visual acuity. Compared to our patient with macula on patient they lose, they improve very few lines here. So as we saw before, macula on patients, the objective is preserve the vision, macula off is to improve the vision. And these are the concordance, the result from our trials. So first of all, we have a good concordance in all statistical study for OCT, both quantitative and qualitative. So when we measure in a good way. Very interesting thing, the only correlation we have in a spectral domain OCT was the disruption of the outer retinal layers, the OSES disruption here, and it is clearly positive here. And the multifocal ERG, they can only explain 50% of the visual acuity for this patient. So it means it can be helpful, but it is not something that you can use based on for diagnosis. So we move on this group of the same group of patients, and we study something a little bit more complicated. So we want to know exactly if the function of every quadrant of the retinal detachment, wherever it was detached or attached, was the same after the surgery. So we choose the same patients, we do a different analysis, and we, instead of analyzing by ring, it means analysis concentrated on the visual acuity function, we need to assess which quadrants. Because we know productively which quadrants were affected, and we can to measure positively if the quadrants were affected or not. So we want to know if these quadrants were affected before the surgery, it get recovered or not recovered after the surgery. And these are results. As you can see here, this is temporal superior, nasal superior, temporal inferior, nasal inferior. They move on here. So there was no association between productivity status on the quadrants and retinal function, which is surprisingly, because it means Patients with superior retinal detachment, okay, they can have better performance in superior retina than inferior retina, even being patient affected in the superior retina, not in the inferior one. And this comes one of the nice results we get it, and probably that's the reason we get accepted as an ARBO. It doesn't matter we cannot retard the retinal detachment you have. Either it's superior, either it's inferior. Always superior quadrants that have better retinal function than inferior ones. It means that probably during the surgery, we do something in the eye that changes the recovery of the retina. And that's what we're talking when we talk about post-spinal vitrectomy as a treatment for macula on patients. If we drain the fluid, probably we make the fluid inferior. And maybe this could be the cause of the low performance of these inferior quadrants after the surgery. So as a conclusion, we don't find any association between the quadrants, but we know that the superior ones are doing better than the inferior ones in the monitor for the retinal detachment. So we do something in the study that changes things. So we go more into this group, and using the same technique, we use another group of patients by at that time, my fellow, now he's a consultant in my hospital. And we do another group of primary retinal detachment, operated by 3 surgeons, same technique. We do first in angiographic. Why? Because we will communicate, there was some communication that they say that if there is this inferior displacement of the first of the retina after a post-spinal vitrectomy. So can you see here in this image exactly, which is the shadow of the vessels, that it makes the displacement of the retina after successful retinal surgery. And this is another example for that. So what we conclude after this study is that there is a retinal displacement after post-spinal vitrectomy like 60% of the patients. But we don't find any correlation to final visual acuity. We don't find any correlation with stereopsis. We know that there was lower amplitude of P1 response on the multifocal ERG in the patient with retinal detachment compared to the other eye of the patient. But in conclusion, we conclude that this finding of displacement of the retina, it's a frequent finding, but they don't have any functional significance in our study. And we go deep into the study of the OCT, because I think we thought that probably was the most interesting area to work. So in this, at that time, we have available this prototype as sweat source OCT, and we can be able to do MFAS images here. So we were interested to know which is better, to study with horizontal caps, with the normal caps we use for SOS for retinal studies, or we can do fast scans, and fast scans or C scans is the scan you have the whole information of the retina in your view. So we thought that maybe the fast scans can be able to get more abnormalities or can be better for diagnosis. And also we try to correlate the final visual acuity. And this is an example, and you can see here this fast scan here with cis fluid here, and you can see also in the cut here. And this is a patient with and then fast scan with a subretinal membrane, and you can see here on the cuts. So the conclusion in our study was the fast scans can detect macular abnormalities in retinal detachment patients, and the outer retinal layers, as you will see that all the time, is the more associated visual pattern in the visual acuity in both imaging patterns. So the patients that have these outer retinal layers is the patients that have low visual acuity. And we found that single horizontal high resolution scans were a little bit better or sensitive more to assess the macular area in course for the C scans. So now let's move on and finish the part of our studies, and let's move on to another part of our conclusions. So how we can assess the function outside the visual acuity. First of all, if we examine a patient with a low visual acuity after retinal detachment, we need to know a good clinical examination focusing on the cataract, because cataract, especially for post-spinal vitrectomy, is the most frequent cause of visual acuity for this patient. Don't forget the refraction. Also with the spinal buccal patients and the patients with cataract for post-spinal vitrectomy. And now the gold standard to examine these patients is the optical coherence tomography, especially looking to the autoretinal changes. But other helpful tests, like a fundus autofluorescence, electrophysiology of visual field, can be helpful, especially in cases that we cannot be able to assess any features that can be evaluated as a bad outcome features on the OCT, but we need to discharge, for instance, this toxicity, or either there was some lack of perfusion of the optic disc that could happen during vitrectomy cases. So when we talk about OCT tomography, the proprietary features, the first description was made with time domain OCT, which in 1999 by Ip and Hagimura. And the first description of the characteristics of the spiral domain OCT, which is the interesting one, is later in Nakanishi. He was the one who started to speak about the association between preoperative OS-ES gaps and low visual acuity postoperatively here. But also, later on, with the better OCTs, with the better quality of imaging, we Cho and Joe describes what now is the mainstay of the OCT characteristics in retinal detachment surgery, which is the presence of OLUs, which is outer retinal undulations, like you see in this draw here in acute retinal detachment, or the intraretinal ray splits. It means the retinal layers get separated in the OCT here. So you can see the profile of acute retinal detachment and a current retinal detachment and the silicone is quite different. And also, when we focus about which is the characteristic of the OCT postoperatively, the first reviews, they speak about the relationship between the ellipsoid zone OS gap and low postoperative visual acuity is the work by Larry Leclerc and Schocket in 2015. But the one who makes a little step on this feature is Wakabayashi and co-workers, because he explained that the patient can be able to repair this ellipsoid zone if the external limited membrane is preserved during the surgery. It means that we not only can assess for low visual acuity, but also can be able to observe and ascertain it will be a progress on the performance of the patient. So this patient Wakabayashi, they speak about the first one who speak about this picture. Also, some of the previous works, they speak about subretinal fluid as a cause of low visual acuity. But these works, we need to put it aside. Why? Because these works will make a time domain OCT, and they lack the characteristics to be able to assess which is the quantity of the anomalies that have in the OCT. So the new works made with steroid OCT, they say there's no association with subretinal fluid and low visual acuity, which actually is what we think right now. So you can see here an example of this repair. So if you see this patient has the external limited membrane preserved, so we can expect that after this repair of the ellipsoid zone here, it comes from the previous work. So here you can see the patient with the external membrane and a gap, and this is repaired after a few months. Just to highlight what is the different behavior of retinal detachment after Cscr. So we have a patient with only subretinal fluid and good visual acuity. Patients with rheumatoid retinal detachment have different characteristics. They don't only have subretinal fluid. They also have a split on the interretinal layers, like you see here. I'm sorry. You have outer retinal undulations and you have interretinal fluid. So this is preoperative imaging, and the vision for this patient was counting finger. Same patient after 2 weeks. Okay, you see the gas here. Look at that. There is no interretinal fluid, there is no subretinal fluid, there is no interlayer separation, nothing. We don't see outer lateral layers, but there is no outer retinal layers. And the vision is 2100. A little bit better, but not good enough. Because this patient has the external limited preserved here, as Wakabayashi predicts, this patient, they will regenerate the visual acuity. And the visual acuity for this patient after 3 months stands for counting fingers preoperative until 2400. So now we can be able to assess on the visual acuity recovery with using OCT only. So last but not least, what we can expect for visual acuity improvement in these patients. First of all, visual acuity improvement in retinal detachment surgery it's a lengthy process. They take longer than 1 year. The main reason for visual decrease is the cataracts, especially in patients operated by pars-plana vitrectomy. And interestingly, the young patients shows better visual recovery potential regarding the lens status or the macular status. Look at that. This is how we speak about that. This is our group of patients, take our data cases. So it's a group of patients treated with pars-plana vitrectomy and gas tamponade, successful tamponade here. This is the pre-operative assessment. So after 6 months, the visual acuity decreased. Why? Because some of the fakey patients, they will develop a cataract here. And after more than 6 months, the visual acuity starts to be equalated at that time. As we saw, as we will be speaking all the time during this presentation, macula on patients, the main goal is to preserve the visual acuity, which actually is totally different from macula patients. They have very low visual acuity at the start of before the procedure, and they improve. Some of them improve a lot after the procedure, and they keep continuing improving after 12 months from the surgery. So the goal for macula patients is to improve the visual acuity. So finally, the take-home messages is the anatomical functional outcomes are related to a lot of factors, patient characteristics, to treatments, to other surgeon choices. So visual acuity improves in macula of patients and is well preserved in maculas after successful surgery. So the better we can do for these patients is to do surgery on the best surgery we can do for these patients. And the highest single success rate is the most important factor for anatomical and functional success. So if we want to improve our functional success, we need to get a better and a higher anatomical single success rate. Another take-home message is when we start to assess this patient, the golden standard, the most valuable test we have right now is the OCT. We need to remind that visual acuity is a slow process that takes us more than 12 years at least to improve. And other tests can be helpful if OCT is not predictive for visual acuity outcome. And thanks for your attention. I'm really happy to take any questions about this topic.
Discuss it, and all patients might having the same scenarios, but their visual, the outcome of visual function is not the same. So there is a lot of factors might influence the success. If anatomical things seems good, then is not usual. Questions in the subjects, and if I could ask, you did your study and using OCT, part that done with perimetry or not in this studies, because this might be sometimes give you more the function of the macula.
Hassan, I cannot hear you well, the question.
Are you hearing me now?
Yes, perfect.
It's okay. My question is about the perimetry, the microperimetry.
Yes. The question of microperimetry, we have some experience in. We have that. We have the same model you have right now here at Cscr. So we were lucky to use it when they start more or less the same problem. But the thing is, we were very interested to assess for some objective measure. The problem with microperimetry is the patient needs to mark which is seeing the target or not. So it means the collaboration of the patient is needed for that. So that's the reason we want to focus on objective measure, because we thought that if we can measure the the macular performance of the patient, we can be able to assess better which is the visual acuity, which is good or not. honestly, I think that the microperimetry can add into that. There is some trials, they use the microperimetry here, but we try to focus only in objective assessment because I know that some of the patients, I mean, there's a long history about that because all these starts, all my interest in this topic start, we was called by a judge to be able to assess a patient with a good anatomical out of a bad retinal function. So the thing is, if we go, I want to see something in pro or against a doctor. I want to have something objective to put on. And the problem in microperimetry is subjective. So it's like visual field. It means the collaboration of the patient. So the patient, for instance, is cheating or is lying to me. The microperimetry, they can something that can be can create a problem. OCT doesn't. The good thing about OCT or electrophysiology is it doesn't make any there's no way you can lie here. Very difficult to lie here. So you can make the decision much.
Yeah, I don't know. Did you miss the first part when I spoke that it was great and excellent, informative, grand round? Maybe you couldn't hear me. Any questions from the attendant audience? Because I couldn't see, just only most of them, they are thanking you for your great talk. Let us to say, as per your experience, when you are comparing the 20 gauge vitrectomy and now the small gauge vitrectomy, and regarding to the anatomical, or as well the functional success, is there any difference in the literatures now regarding to this?
We when we started this study, we were doing 20 gauge vitrectomies. So I cannot tell you about the 23, but honestly, the last series of patients, all of them are 23 gauge vitrectomy. So I can tell you right now that probably we are going to find the same thing. And also there's some trials they got studied because I told you, I was reading there's 78 papers published in these last 3 years regarding this outcome. So it's a hot topic in retinal detachment surgery right now. So some of the papers that don't find any difference compared 23 to 25 at all. So I don't think it's huge difference between 20 and 25 here. As long as the technique is doing the same, I think we can proceed and extend the same assessment to the new patients we have here right now.
Okay, regarding to using Tunblat, talking about gases.
Yeah.
It doesn't. Is it having any influence in the final functional outcome? Either your C3F8, SF6.
Yeah, I told you, Hassan. One of the things that I was highlighting in the study is that we want to study a very small group of patients. We want to study patients with pars-plana vitrectomy without the scleral buckle, with gas tamponades successful. Why? Because if we can to mix tamponades, different surgeries, different macula on, macula, whatever, we never get conclusions. That's what happened with all retrospective studies, that some of them, they have 2,500 patients, and they compare something ridiculous. And also, I have to make a point into that. You know the Heyman study, one of the super studies they make in Heyman, and it's very interesting, that one is because they study the surgeon performance for scleral buckle or vitrectomy. And surprisingly, the articles in German, I can be able to accept to a translation to this article, some of the surgeons were included in the study have 0 success rate with the scleral vitrectomy, and some of the surgeons have 0 success rate with pars-plana vitrectomy. So you are randomizing our hereditary with a guy who doesn't know how to do the surgery. This is what happened. So all the conclusions dedicated to the study, we had to put between brackets because it's really difficult.
Yeah, I think that the point that's difficult to achieve, is the correlations, between, functional and anatomical. This is, anatomically is easy, we can assess, and most of the times, and the clinic trials show that, even though in the latest, reported, trials, that combined procedures, both of SP with vitrectomy, seem that superior a bit in certain cases when you compare it with the primary vitrectomy. But correlations between anatomical success and functional success, I think most of the patients, they might achieve good visions, but when are looking for the quality of vision, definitely there is difference between them.
Yeah,
Do you agree with that?
No, I totally agree with that. We're talking about difficult topic. It's not the easy one. But the problem is, the thing is, and I think that one of the main interests to highlight here is at least we have one type of study we can repeat and do in different patients. For instance, I only study patients with gas tamponade and pars vitrectomy. But for instance, I'm putting more silicone oil here than rather in Spain. Why? Because most of the patients that did in Spain, they were from the same area. So I can be able, I don't need silicone oil in these patients. But most of the patients that do here, they came from outside. So you can repeat the same study using silicone oil tamponade and see if the conclusions are the same or not. But at least we have one model of study we can use, because when we measure the visual acuity, the OCT characteristics, and the multifocal ARG, we have some pattern to follow up. Because one of the most difficult things when we start to think about this is how to find something with this perspective and can be able to give it values information for you.
You mentioned that about macular displacement, which is nowadays is seen that obvious and a hot subject that to be. How we can avoid it as seek for all of the new vitreoretinal surgeons?
Usually, when I think about this subretinal fluid displacement after pars vitrectomy, honestly, I'm not really afraid. If you check right now the literature here, it seems that even macula on patients, if you operate in the first 3 days after they will become macula off, the visual acuity are the same. So something we will do in the operating theater, as long as we put the patient face down, which is the key to be able to flatten the retina. So you put the patient face down immediately after the surgery, you can flush the fluid here. So don't be afraid to let some subretinal fluid behind the macular area. I'm not really fond of doing posterior retinotomies to aspirate the subretinal fluid, because as long as you let small fluid here, we know from these studies and our studies also, the subretinal fluid is not a variable that's going to lower the visual acuity for the patient. So as long as the position of the patient is the right one, we can achieve a good visual acuity outcome without worrying about that. Maybe what we found in our study about the superior and the inferior retina, I cannot tell you, right? Because it's something that is really difficult to explain why. But honestly, it's clear because it's something objective, that something we do during the surgery that changes things. Because if you have the retina to superior retina detached and becomes inferior impairment, it's something that the logical doesn't tell you that way. But this is our numbers. This is what we're going to do. Maybe if we can be able to study different scenarios, different outcomes, more patients, we can get a better conclusion, because all of them were pilot studies about that.
Sometimes during the surgery, when you are draining your, subretinal fluid internally from any pre-existing breaks, but sometimes you might leave some SRF, and the macula not completely 100% flat, even that you put perfluorocarbon there. So is that having any relations to possibility of outcome?
Yeah, I mean, as I told you, this topic is really huge. a huge topic, but it's something to know about perfluorocarbon. People they don't know. There's studies from the group that they do intraocular OCT, the group of Baltimore. They have a paper which shows that patients with subretinal fluid, when they put the perfluorocarbon, they always have fluid. So one thing that even if we put perfluorocarbon, we're rid of the fluid. The fluid is still there. Okay. So the thing that it's not as bad as it seems to let some fluid to the retina, because as we saw for the Scalbakel group, which is visual acuity is the same as pars vitrectomy, and also if you see this patient with high success rate for retinal detachment, the funny thing is people they do highest rate of success, they use less perfluorocarbon. So we don't think perfluorocarbon is, if we need it, we need it. But we can get rid of this. It's not something that's going to worsen the prognosis for the patient, for sure. But as I told you, there's a lot of factors that Hello? Can you hear me?
That's good you mentioned it, because perfluorocarbon, as there is some brands, is really some sort of toxicity This is
Yeah,
it's
yeah,
difficult.
exactly.
I mean that some being it's not a good brand. I don't know. Maybe Marco.
We suffered that in Spain. We lost like a 27 eyes for the perfluorocarbon toxicity here. So it's something to take into account. Everything we put into the eye, but not only perfluorocarbon, dyes, 3-ensinolone, everything we put to the eye is a risk we are assuming.
Really, that's yeah.
So
But
the easier, the better.
Yeah. If there is no more questions,
yes,
I would
Dr.
like.
Hassan?
ايوه تفضل دكتور عادل.
Thank you, Marcus, for a very nice presentation. I think it's a very important subject, and it's really difficult to really find this correlation between the vision and the anatomical outcome. And I think you've done a great job in demonstrating how important, what are the limitations and how we can achieve, let's say, an understanding of the vision in this situation. My question is about the timing of the surgery. You've heard about the recent article that talked about the higher chances from Lee. It's a group in the UK. They talked about the higher chances of vision improvement if a macula off RD is done within, let's say, 3 days from. I think they talked about 3 days after the incidence of the detachment. Have you, in your experience and in your opinion, you talked about detachment. Is there any limit value to interfere early, and when it's too late to really even consider interfering in terms of the timing?
My experience, I tell you the experience I have here back in Barcelona, because I try to get from, because different practice, different outcomes, and I try to get it. I also read this paper, and honestly, I mostly agree with the conclusion of this paper. So when you do retinal detachment, is your macula on patients, it becomes macula off. It doesn't matter, it's a few days. As long as you don't go more than these 3 days. 3 days, since it's the landmark, though, if you go further, you begin to lose vision on that eye. But we are focused about a lot about which is the timing of the surgery. And honestly, if you see the work from Weil and collaborators, if you have a retinal detachment next Friday, Adele, we're going to put pneumatic retinopexy for you. So this is what surgeons do. So
yeah,
why?
I think
Because
the conclusion,
we'll put the gas and see what happens.
Yeah,
So
as soon as possible. As soon as possible that you have the facility, do it. And as you have macula off for 2 days, 3 days, I would treat it as a macula on patients. And usually,
if you do as soon as possible, you are fine.
Yeah.
Any more questions?
I don't know, Marco Mora.
Awesome.
He was with us. If he would like to say anything, maybe it's not. Really, it was an informative and super excellent grand round and very wide. أيوة دكتورة سوسن.
Yes.
Go ahead.
May I put
You
a
have
comment?
1 minute.
Thank you. Thank you very much. First of all, thank you very much, Dr. Marcos Rubio, for an excellent presentation. The way I remember doing surgery is that you have to do the minimum number of things that gets the job done. Meaning, when you are an experienced surgeon, you decide based on your experience, what is the minimum number of actions that I need to do to get the retina attached in one single surgery. And the minimum can be just putting maybe just a radial buckle, and then leaving this, or going all the way to silicone oil and doing a retinectomy. It depends on the case. So I think all these studies that look at the anatomic results and the functional results, and mostly the anatomic results, you cannot really make a lot of you cannot really base and or get a lot of information from them, except more knowledge. But finally, why is that? Because as you correctly mentioned, there are so many factors involved in terms of PVR, in terms of extent of detachment, in terms of, you know, the timing of the retinal detachment repair and the surgeon's usage of different things. So it is very difficult. I really agree and think, I don't know if you agree with me, is the best way to determine if which procedure is better is to have each surgeon by him or herself analyze their results, meaning, okay, in this type of situation, the people tend to have a certain attitude and certain habits of doing things, and then decide, okay, what is my personal best rate, you know, best outcome, if it's a vitrectomy, or if it's a buccal, or if it's a pneumatic, or a combination, or sometimes even within specific vitrectomy procedures. For instance, like, are my outcomes better if I had used perfluorocarbon to drain, or are my outcomes better if I had used, for instance, a retinotomy to drain? And this is very, very tedious, extremely long, but I think this is the only way to really find out eventually, you know, which procedure works better for which detachment. I don't know if you agree with me.
Yeah.
Yeah, it's awesome. Definitely, I agree with you, and thank you for your nice comments. But I also will add some things about that. We don't do so bad. Look at the numbers of the
Of course.
we can be able to flatten 85% of our retinal detachments with only one surgery. So this is something in 1919 was dreaming on. And Dr. Aldivi can answer about that, because he has experience from the, I mean, the middle generation. We has experience for the previous one. So we can be able to flatten half of the patients. That's what my mentors do. So they say, if the retina, you're doing 50% of success, is a good success rate. Now we're doing 85%, and then now it's like, oh, you are not going to go to 100%. Let's be, we have to be also.
I agree with you. I agree with you fully. The only thing is that if we're trying to compare which is better.
Yes.
Yeah, but also, I mean, the result we do achieve with this,
I think we exceeded.
Excellent.
Okay, thank you.
I think, yeah, anatomical success from one surgery. I think our next step that to improve our functional quality of visions. I think this is where we still, yeah, we are not sure about it, how it is. But then I would like to thank you all for your attending this, you know, grand round. Thank you, Dr. Rubio, for this is really an excellent, great grand round. And see you, inshallah, in next grand round. Thank you, everyone.
Thank you. Thank you very much.